And thank you, Abbott, for giving me this opportunity. I'm really excited about this technology when it came in. For us as interventionists and interventional electrophysiologists, we've been very familiar with steerable systems. And what is the goal here, right? The goal is to implant a device with minimum amount of leaks and it can fit in properly and provide any proper separation between the disc and lobe and avoid any device-associated thrombus. And if you use a prefix system, left atrial appendage, comes in different variations. And if you use a fixed system, you have to rely heavily on where you do your transeptal. And as I'm going to show you a case towards the latter part of this presentation, where regardless of whatever you do, sometimes you're never able to get that inferior stick that you want. And in those cases, really, this kind of sheath is the savior. So what is the difference, right? It's a controlled maneuverability to achieve coaxial alignment. The key in left atrial appendage implantation is to actually get coaxial to how the appendage takes off. This sheath has one-to-one takeoff and two-way deflection, and I'll explain to this in a little bit as well. And the best thing about it has an auto lock which maintains the tip position, so you don't have to struggle holding the sheath. And I actually brought a sheath here to display as well. So if you deflect, it goes in one direction, so it helps you with the posterior. And then if you have a chicken wing, you can counter, and it goes all the way up. So even if your axis is down, you can coaxially align the sheet, deploy the device, and use it. So it gives me so much variation where I can deploy the device the way I want it. So this is an example for it. It's the one-to-one torque and two-way deflection, as I described, 120 degrees and counterclock all the way up. So some of the difference between a standard fixed sheath and a deflectable sheath. There's variable stiffness that exists. The best part, which I like about this sheath, that there is a atraumatic tip. So as you are deflecting this, the chances of damaging anything in the left atrial appendage are minimum, as compared to a fixed sheath where you see a constant stiffness that they have to maintain because of the wires which are running. Then you have the proximal curve, and then the distal curve as I described. So what other differences are there? And definitely in a steerable sheath, the usable length is a little bit less, but the overall length of the sheath is longer. The size is a little bit more, but for me, in most cases, even if the device that I choose is smaller, I would probably favor this, especially in cases where I feel that it has a chicken wing or interior takeoff, that I'll have to use deflection to align myself. Proximal curve is similar, 45 and 45, and then the distal curve, as we described, has that rotational capability where you can align yourself coaxially to the left atrial appendage. In most cases where you see failures such as leak or leaving gaps so you can get device-associated thrombus is because your deployment is happening and you're misaligned to the long axis of the device. This particular talk is not about the actual deployment procedures, I think, but how I can maximize my workflow, where I can have one system where I can fit any kind of device in without leaving any leaks behind. The dilator shape is same. The hemostatic valve is off the shelf because it's really on the proximal side. There's a hole that you can connect, and then you have flush adapters, which are similar. Okay. So the other thing is the torque translation is very similar to what we used to, which is the Agilis sheath. The force is placed on the handle to get translated to the distal end. So I'll display that in a second. So for any sheath, the responsiveness is important. So let's say if I click at one time, you see the sheath happening here. And then the other thing which for any deflectable sheath which is important is what is the feedback that you're getting from this. So the feedback is very similar what we're used to, which is a deflectable sheath. So if this is really, really stiff, sometimes you feel a lot of resistance here, and you don't know if you're against the wall or not. But here you can tell if you're against something and you deflect, the feedback to your hand is actually very, very good. So you don't have to rely heavily on fluoroscopy as well. So if you're against a structure and you're deflecting, you will feel it in your hands and adjust accordingly. There is resistance to bending, as we talked about, and really, I mean, it's pretty impressive what they've done with it. If they're able to replicate what we're so used to, which are the deflectable sheaths. The proximal curve, as we talked about, is fixed, and the distal curve is. Okay, so what is my workflow, right? The most important part of the procedure is the transeptal puncture. So your goal, whether you're using intracardiac echo, which we do in a lot of cases, or transesophageal echo, you want to be able to go as inferior as possible. And then, depending on the kind of of the left atrial appendages, either you do a mid-stick or an anterior stick. And what does that mean? Well, you want to be able to see, if you're doing an ICE, you want to be able to see left atrial appendage and the ridge when you're doing the transeptal axis. On a TEE, if you're doing it on a long axis where you have the SVC and IVC, you want to go as low as possible to where the IVC, almost the IVC is. And then on the short axis, you want to be able to see the aorta, and you just go behind the aorta. And if you do that, in most cases, if you have a deflectable sheath, you should have no problem aligning yourself to the long axis of the left atrial appendage and close any appendage. So we had some data, which I'm not going to share here, but which which got accepted in APHRS and TCT as well, where we have stopped doing any CT scans for our patients. So we don't do any screening. We just do TE on the table for the patient, because we have enough confidence with the tools that we have present currently that we can close any appendage unless there's a thrombus in there. So based on the data, our device usage has been in the range of around 1.1 to 1.5, which means there are only 3 to 4 cases where we had to use 2 size devices. So what you see, you can close with this, and the leaks were there was no leak more than 2 millimeters, at least on follow-ups for 3 months. We do follow-ups in 45 days, 6 months, and 1 year. So going back to this. We typically exchange a wire in the left upper vein, remove the dilator, attach the flush adapter. Now, one of the things that the company is working on is a zero exchange method, and that's something which may come in the future, where you actually, and this will be ideal for me, that I use a deflectable sheet to do my transeptal as well. Why do I do that? Well, this is how we do it with Fluoroless. You go into the superior vena cava. It has a curve, you drop it down. Now, a lot of time, right atrium may be large. So if you use any kind of fixed sheath, if your right atrium is really large, or your angle from your IVC to the septum is very big, you may not reach the inferior part of the septum. So what we do is, in a deflectable sheath, we deflect. Even with a dilator in, I don't think there's a dilator here. It's a misconception that with a dilator, you cannot deflect the sheath. Even with a dilator, you can deflect the sheath, and it will transmit some of the torque to it. So you will be able to bring it down. So for me, all transeptals I do with a deflectable sheath. So I would typically take an Agilis, do the transeptal, exchange the wire, and then put this in. Now, as this, what the company is working towards is zero exchange, which means that you will have a wire, stylet, whatever you have with a dilator, that eventually you can do the transeptal through this as well. And I can foresee that happening in the near future. So you do the transeptal, you put it in, currently you do the transeptal with the deflectable sheath. I put my wire in, and then I do the exchange. In our cases, we actually, once we dilate, we put our intracardiac echo in the left atrium as well through the wire exchange, that helps me minimize my fluoroscopy and sometimes even usage of TEE. Then I will advance the pigtail through the sheath and then enter the left atrial appendage. And at that time, I will confirm my sizing whatever sizing I've obtained on a TEE or the ICE, and I confirm on the angiography. Now, pigtail is just to guide you. I don't typically do an angiogram through the pigtail. What we do in the workflow is we already have a copilot with a pigtail connected. So as soon as I take my dilator and wire out, I'll have my copilot with a pigtail ready to go, which gets connected here. And then I will advance my pigtail, cannulate the left atrial appendage, get my sheath closer to the orifice of the left atrial appendage, and then perform an angiogram from the deflectable sheath. Now this helps us size the device because this has a fixed size, and you can use that to size. So I always talk about Amulet as two-step process. One is the right side cerebrum and the left side cerebrum. One is you want to understand the lobe, which is the proximal part of the device or the distal part of the device. The function of the lobe is to actually anchor the device in there. So that is the thing which is going to stabilize your implant. And then if you're not able to close everything with the lobe, it's not the end of the world because you have a disc behind. So that's why it's called dual seal closure, because you have a disc behind where you can close the rest of the stuff using the disc. Okay, so what we define when we do the angiogram, we define our landing zone. What does that mean? Well, we will park our sheath right past the circumflex where we think we will deploy our anchors on the lobe. And it doesn't have to, unlike the competitor, it doesn't have to be distal. Typically, it's quite proximal, right past the circ. You don't have to go fish things in, and that's where we size it. And the other thing about this device and sizing is the sizing has to be appropriate. You don't need to over-compress. You don't need to under-compress. And there are several sizing options which are available, which fits the picture well. The other thing about the implant is, which I didn't mention in here, is you have to be careful about deeper implant in another way because there's a connection between your lobe and your disc. So if you do a really, really deep implant, the disc is going to get stretched and get pulled in. So you want to place it properly right at the ostium past the circumflex where there's enough distance between the disc and the lobe, typically not more than 12 millimeters or so. Anyhow, we position the sheath at the landing zone. Then we typically advance the device in this ball mode. So there is the ball mode. And this is where the deflectable sheath does so much for us, because this is a beautiful picture where you see you're aligned. A lot of times your transseptal axis is going to be like this, and I'll show you an example. A lot of times transseptal axis will be like this. A lot of time there will be nothing here. The only room you have is in an anterior chicken wing right here. So what the deflectable sheath does is help you just line up your ball. Okay, so you can deflect posteriorly, anteriorly, and try to get as aligned to the long axis of that appendage as possible. And once you're comfortable with that, sometimes you can counterclock in the ball mode as well. The next thing you do is get it into a soft mode. And what it means is you'll make a triangle. When it becomes a triangle, typically the distal part, which can be traumatic, becomes really, really soft. And now you can push a lot of device into it, and that's called the low mode. So that's where we maintain a lot of forward pressure to try to deploy the lobe in. And typically the lobe should sit in here past the circumflex with no kinking and all that. And then you typically I do an injection or look at ice to make sure that there is no leak around it. And then I would deploy the disc. But if I'm not happy with my lobe, I typically do not deploy the disc. I would always make sure that I'm maximally pleased with my lobe before I do that. And then so unsheath the disc and then close assessment criteria. So there you go. So this is another example of how you can align yourself to get better. So let me run you through a case which was quite a humbling case. This was a gentleman I recently did a persistent atrial fibrillation ablation on, and could not take long-term anticoagulation. This is a TE there, and I didn't show you the transeptal in this case because of restriction of time and stuff, but it was extremely difficult. His septal wall was extremely thick. I couldn't go inferior, and you'll soon see how I access the left atrial appendage. So despite my best efforts using ice, using everything, I just couldn't go low enough. So you see it was quite humbling. You can see this is not the way you want to enter the appendage, right? It's too high. You're coming out here. You want to be able to access here. But if you look at the long axis, right, there's no way for me to enter the left atrium like this, right? So I had to work with this. And then if you look at the 135 view, look at how my sheath is taking me over here. Ideally, I should come in this plane. And the size of the left atrium and the angulation that the appendage takes off is pushing me over here. So imagine life without deflectable sheath, right? If I deploy here, the device is going to be canted and difficult. So anyhow, I think this was part of one of the live cases I was doing, so we had to move relatively quick. This is what the initial deployment as expected. See, I did a little bit of deflection. I was able to get a little bit more aligned here, but despite that, when I deploy the lobe, the device looks a little canted, right? Typically, you want the anchors of the device sits here. So one anchor looks like it's connected, but the other anchor seems like it may be off a little bit. So when you want to see the lobe, you want to see the lobe sitting in a way that it's perpendicular to your appendage takeoff, so your tines are connected. Even on this view, you can see that it's pointing down posterior a little bit. But having said that, because we were having a little difficulty with it, I decided that maybe I should take it and see how the disc looks. When I did an angiogram in this, I didn't see any leak beyond where thing was, where the lobe was connected, so I decided to go with the disc. So this is what happens. And I think it's a good example for everyone to see it. So one of the things when you do the disc is when you unsheath. So when you do the disc, you see that the lobe, why is this happening? So I won't put the pointer, but I'll just show my finger from here. So I unsheathed it and the disc came in, but the disc fell in a little bit inside, as you can see, right? Towards ideally you want the disc to be pointing outside at the antrum. But the good thing was that the lobe remained fixed. So you have tension on that lobe, but the lobe is not moving. Can everybody appreciate that part? Okay. Did you get it too as well? Okay. So this is where this is another example. This is this is a better example, as you can see. The disc sits inside the transverse sinus. So from my standpoint, this was probably a slightly deeper implant, and the way the axis is, it's trying to suck the disc in. Now, ideally, you want a little bit separation in the two, you don't want to leave any gap in this top area. So what can I do at this time? Any suggestions? Anyone wants to suggest? So we had two options. One, I go ahead and recapture everything, right? And then try to deploy it with a different angle. Or this is a time where you can actually use your sheath to put the disc on top of your orifice. So this is what we decided to do, and you'll see that over here. So what we do is we unsheath, we pull our sheath back a little bit, and then you pull on your wire, so your sheath, your disc actually comes out a little bit, and then you can use your deflection to actually sit the disc wherever you want. So if you want to sit the disc towards the pulmonary vein, you can deflect it up, okay? If you want your disc to sit a little bit towards mitral valve, then you can clock it and you can sit the disc lower. So I'll show you an example of this, and this is what we did in this particular case. I was able to sit the disc on top. Now the implant looks much more acceptable, but I was still not happy with this. Why am I not happy? Because I have a little bit of, there's not much gap between this disc and this lobe inferiorly. And this is part of the closed criteria. So even though the appendage is closed, so a difficult appendage that didn't close completely with the lobe, I was able to close with the dual seal technology. So that's what makes my life much easier. And then, because I still wasn't happy with this, I decided to recapture it and try a different technique with the deflection. This is not unacceptable in most cases if you're starting with this, but because we've had quite a bit of experience with Amulet and deflectable sheath, I wanted to give a perfect result. So as you can see with color, I have no leaks happening even in this, and there's nothing going past the lobe or even the disc. But I decided that maybe I can do a little bit better job. So what we did was recaptured everything. It's the same device. And then made a ball. This time I used a little bit more deflection. And you can see now I am getting better alignment. If you see the ball over here, it comes in, right? And then the alignment or axis to the left atrial appendage is a little bit more. Now this required a lot of deflection. You can also even see my sheath is getting away from this. So I had to deflect a lot to get this and put a little clock to it to get it more aligned. So once we did that, now this is the triangle form. You can see it's much more coaxial in the 135 view as well. Can everybody appreciate that? So if I had a fixed sheath, there is no way I would have been able to do this, even with maximum counterclock and stuff. So that's the advantages of using a deflectable sheath, where you can actually, even when you're limited with your transeptal axis, because the wall is too thick and you just can't go inferior enough, a deflectable sheath can come save the day for you. Now, one of the other things is that this doesn't mean that you can now do regular transeptal axis, right? Try to get transeptal axis anywhere in mid and stuff. It doesn't change that. You still should try to get as inferior as possible. You still should try to go anterior mid as possible, and then following that, if you can't, then this deflectable sheath. So now you can see that it's a little bit more aligned. I'm in the triangle mode, so I'm going to go into in this case I directly went into the lobe mode, and you can see the device now just takes its shape. There's so I come around here, I can point it as well. This is, where's the pointer? This. So you can see the lobe sitting here. The deployment is a little bit more proximal, and your disc is sitting right on top of it, and there's no, as you'll see in the next slide, there'll be no color flow in there. We also do the angiograms as well. I didn't have time to put the angiograms in there, but so this is another example of the TEE, where you can see that this disc completely closed. I also used my sheath to try to, oh sorry, let's go back one. I also used my sheath to try to put this in as up and away from the mitral valve as possible. So you can see the disc sits beautifully. It has a concavity to it. And then what I love about these is after 45 days, when you look at the TE, the endothelialization, you can see it looks like part of the heart. So there's nothing sticking out. It looks concave. It looks really, really nice. You want to avoid the pulmonary vein ostium. You want to avoid the mitral valve incising. This is the color flow. As you can see, there's nothing going in. And you're safe distance from the mitral valve, as you can see. This disc has a nice concavity to it. And when you release this device and you bring them back for the re-imaging, Yeah, it looks really, really nice. This is after releasing the device. You can see we did a contrast shot, and there's no leak around it, and there's no crevices left. Another picture of the final. So this is the 3D picture, as you can see. It's called the figure 8 sign, and you can see that, again, the concavity is in, and there's no leak around the device. So this was just a tough example of what the point I was trying to move. I think it's the steerable sheath is an important advancement in left atrial appendage occlusion. It has become my workhorse, much similar to what Agilis is for our RF ablation. It really makes your life easier. Even if you are hit by a surprise when you go do an implant, there's so much you could do to actually get a better result. You know, if you go with a fixed sheath, you may have to settle with suboptimal. And I think for our patients who expect to come off anticoagulation, if you settle for suboptimal, you will have to leave them back on anticoagulation, and I think it's a little unfair. So if you do have technology available which can make you a better implanter, why not? The bidirectional steering, it is a little scary. People think that, hey, listen, you know, how am I going to use a steerable sheath inside the left atrial appendage? Everybody is scared of left atrial appendage. What if a perf happens? But the tip is soft. If you're careful and use it appropriately, we haven't seen any complication related to that, knock on wood, long term. Improves positioning of device, as in this tough example as I showed you, reduces the number of multiple repositions. So, you know, you don't have to take it out, do a second transeptal, try to get the different transeptal. Now, I didn't show you an example of a chicken wing, but these works amazing for anterior chicken wing, which are typically the referrals that you get for you know, Watchman failures for Amulet implant. The 120-degree rotation allows you to do the sandwich technique. What does that mean? Well, if you have a chicken wing with an anterior takeoff, you will put the sheath, like go inferior, put the sheath like this, and then sub-select that wing, and then actually make the ball over here in the wing and deploy the lobe. And then you put the disc on the orifice. So that actually the anterior chicken wing lobe actually serves as a barrier between the lobe and the disc. Do not forget your transeptal is still important. If you go too high, then no sheath will work. So you still have to get an inferior stick as much as possible. There's still need for some minor counterclock and clocking rotation, and does not replace. So with that, I'll stop, and we'll be happy to take questions. And
well, let's give Dr. Siddiqui a round of applause. Thank you so much, Dr. Siddiqui. Does anybody have a question?
You do?
Yeah.
Huh? Well, Debbie has a question.
Dr. Nair?
Oh, you are going to give
Yes, ma'am.
Usman, how do you decide which anatomies you pick this and which anatomies you don't pick an amulet?
Oh, God. Okay. Amulet or sheath or? Okay. Right, exactly. So, because of what we've seen, actually, I'm doing almost everything Amulet. And if it's a straightforward shot and I can do the transeptal really inferior, and it is known as a small device, then I'll take a fixed sheath. But in most cases, I'm using a deflectable sheath, even with smaller device. So because we don't do pre-imaging at all, we don't do any CT scans. I think if you are doing a CT scan, you probably can decide to go one device or the other. But if you're not doing pre-imaging because of the way our practice runs, and we have so many procedures to do and so many patients to take care of, and it's a little inconvenient for the patient to come in to do CT scan, I typically just go directly with this, because so far I feel really confident that we can close everything with this technique. And it's been working so far, but once I start having failures, I'll let you guys know. You had a question, Andrew?
I did.
Okay.
Do you see any issues coming around when you have very acute angles?
sorry.
Okay.
So my question was, when you're deploying with an acute angle on the steerable sheath, do you have any difficulty actually getting around that and getting the device out?
No, actually, that's a great question. That's the intention of the atraumatic tip. So because it's so soft, unlike some of the other devices, as you come out, you don't have an issue. Yeah. Good question.
So we have one more back here.
Hey, Dr. Siddiqui, thank you for the presentation. Hey, quick question. So thank you for sharing that case. The device size fit like a glove. Can you talk us through, if you're not pre-screening, how did you land on the perfect size for that patient?
Oh, yeah. So measurements during. So we do a TEE at the time, just to rule out clot. So if you're using a TEE or if you're putting an ice in, that's how you typically measure it. So in most cases, if I have an anesthesiologist available or a TE operator, we would do a TE as the patient's on the table, getting intubated to rule out LA clot, and that's where we size it. But we don't typically open the device unless I have an LA pressure and an LA angiogram, so I confirm my findings with it. There are some surprises which can happen. So what you measure on TE may be off a little bit on the angio, and then so you try to get it. But in deciding the device, you have to think right and left side. So what does that mean? Well, if there's a lobe, but the orifice of the antrum, orifice of the left atrial appendage is very big, then you tend to go on the higher end of the spectrum. So which means that, let's say, the measurement comes out to be 22 millimeters at the landing zone, and you have an option to use a 25 device or a 28 device. You will look towards the orifice and see what kind of disc you want to close it with. So if the orifice of the disc is, let's say, 35, then you'll go with a 25. It's 35, then you'll go with a 28 kind of device, because you want to close the orifice as well. You don't want a small disc because it'll get sucked in. And then if it's towards the smaller side, then you choose the 25. So you have to think both sides. You want to make sure that you don't leave any shoulder off the disc towards the mitral valve or towards the pulmonary vein, and then at the same time you don't want to put a smaller device will begin. And this will become really important as we start doing concomitant procedures, where we're closing this with Amulet device. So you don't want to be interfering the pulmonary vein antrum where you typically are going to go ablate. So if you choose to do the device before your ablation. So good question. So that's how I size it. Yeah.
Wonderful. Any other questions for Dr. Siddiqui? Okay.
Thank you.
Thank you again, Dr.
All right,
Siddiqui.
good.